Good evening, ma'am. I am Gowtham Varma, final year MBBS student from KMC Manipal.
Very good.
Ma'am, I am going to present the case of a 11-year-old boy
Hmm.
who is currently in 5th standard, hails from Karkala. He is right-handed. He's not forced to right-handers at earlier. He is naturally right-handed and informant is self.
Yes. Oh, he's
Coming
going to inform. Huh? That's very good.
Yes,
It's a
ma'am.
small child, no?
Yes, ma'am. Ma'am, along with mother helped with some additions, but he is the main informant, ma'am.
Okay.
Ma'am, coming to the chief complaint, he complains of difficulty in walking, that is dragging of right lower limb since 6 months. Coming to the history of presenting illness, he complains of dragging of right lower limb, which is more prominent while climbing stairs, which is insidious in onset, gradually progressive since 6 months. It is more prominent on climbing stairs. There is no history of excessive bending of the trunk while climbing. Do not complain of swinging across the limb to lift it to the next step. And there is no buckling of the knee during climbing. He complains of tendency to fall front while walking, that is tripping. Complaints of slippage of the slippers knowingly, more common while climbing stairs. Ma'am, coming to the negative motor history, there is no history of loosening of clothes, no stiffening of the limbs, no difficulty in folding limbs while climbing stairs, does not complain of difficulty in combing hair, lifting his books, picking up books from the shelf, and he does not have difficulty in opening his water bottle cap or buttoning his shirt. And he does not complain of getting up from the bed and lifting his head from the pillow. He is able to carry his school bag. No history of difficulty in breathing and difficulty in swallowing. And coming to the sensory history, no complaints of loss of sensation on touch, no loss of cold or hot water sensation while taking bath. He feels pain during injuries in daily activities. No history of falling forward while washing the face. He is able to feel vibration of the auto while traveling in it. No history of band-like sensation, and no complaints of tingling or lancinating pain. And no complaints of increase or decrease in sweating and dizziness after standing from sitting position. Ma'am, coming to the cranial nerve history, there is no loss of smell, no history of blurred vision or diplopia, no history of difficulty in moving eyeballs, no history of loss of sensation such as cold and hot water on face, no deviation of angle of mouth, no history of difficulty in blowing the mouth, no history of difficulty in opening tightly closed eyes, and no history of hearing loss or tinnitus, no history of loss of taste sensation or dysphagia, and no complaints of moving neck from side to side and up to down, and no history of difficulty in protruding the tongue. Coming to the bladder history, sensation of the full bladder is present. No history of difficulty in initiating micturition at will, that is there is no hesitancy, and no difficulty in voiding the bladder, and there is no history of precipitation of urine before reaching the bathroom. Coming to the cerebellar history, no history of swaying to the sides or forward and backward while walking, no history of involuntary movement while picking up a glass of water from the table, and no history of twitching or flickering anywhere in the body. His scholastic performance in school is decent. He acquired his development milestones similar to his peer children. He is adequately vaccinated, including polio vaccine. Coming to the etiological history, there is no complaints of increase of thirst, increased frequency of micturition and weight loss, no history of weight gain and intolerance to cold, and consumes food prepared with iodized salt. He consumes occasional non-vegetarian in the diet and no history of blood in the stools. There is no history of chronic diarrhea. He is not excessively tall to his age. He consumes municipal water and no lead painted walls in his house. No history of deep wounds or that are contaminated with dirt. Not taken tetanus toxoid vaccine recently. No history of any intramuscular injection in the gluteal region recently. No history of no history of joint pains and rash. No history of increased weakness as day progresses. No history of blood in the urine and purpura. No history of abdominal pain, failure to thrive, and rash in the sun-exposed areas. There is no history of complaints of tingling or pain in the first 3 digits suggesting carpal tunnel syndrome. No history of easy bruising and hyperextensibility of the joints. No history of palpitation, dizziness, dyspnea, or edema of the lower limbs. My provisional diagnosis, I'm thinking more of hereditary motor neuropathy which mostly of the charcot-marie-tooth is most common hereditary motor neuropathy. So I'm thinking it as first differential, and CADP, which is MADSOM variant, which is more motor, and also muscular dystrophy and distal myopathies.
Okay, let it be there. We will start analyzing the symptoms. No,
Yes, ma'am.
you have given elaborate history, but apparently, according to you, this is a 6 months duration illness. No,
Yes, ma'am. 6 months. Yes, ma'am.
so it's a relatively short duration.
Yes, ma'am.
1 point, short duration. Second thing, it is asymmetrical according to your history.
Yes, ma'am.
So and his problem is starting as subacute onset, slowly progressive dragging of leg.
Yes, ma'am.
That's what you told, no?
Yes, ma'am.
When do you tell somebody is dragging their legs? You told dragging, no? That's an inference. You are undergraduate student, no? So when you convey an inference, what
ma'am.
exactly you mean by dragging is very important for us to know. So when do we say that somebody is dragging?
Ma'am, if there is no lifting of the foot above and
Correct.
ma'am,
So if somebody is not clearing the floor.
yes, ma'am.
So when you are walking, if you are not clearing the floor, normally when we are walking, how do we walk? First we will stand. No?
Yes, ma'am.
We will stand steady. To stand steady, what is the normal distance covered between both feet? It is called stance. Stance is the
Yes, ma'am.
distance covered between 2 feet for stable standing. If the
Yes, ma'am.
stance is more, you call wide base. If the
Yes, ma'am.
stance is less, you call narrow base.
Yes, ma'am.
You know all these things, no? These
Yes,
terms.
ma'am.
So generally, even though for an adult it is about 30 centimeter, for every human being, we say 1 foot diameter of that person. You see, for a newborn child, it is 1 foot. For a not newborn, a child who started walking. So it is 1 foot of the person. If it is the 1 longitudinal foot of the patient is the distance covered between 2 feet for stable standing, you call it is a normal stance. If it is less than that, it is narrow stance. After the standing, what do you do?
Ma'am,
You have to oppose the pull of the gravity. When you are standing, your gravity is pulling you. So you have to oppose the gravity of the pull of the gravity. So that part of the initiation of walking is called anti-gravity stretch. So you have to oppose the pull of the gravity and clear the floor from the gravity. So if you cannot clear the gravity, you will appear glued to the floor. So you are standing with a normal stance or more stance, because I know you are a small boy. Keeping that in mind, I am trying to explain. If there is difficulty, tell me. No? And after that, the patient has to oppose the gravity. If he is unable to oppose the gravity, he will stand glued to the floor.
Yes, ma'am.
The first part of walking is anti-gravity stretch. So when they are glued to the floor and they try to move their trunk and they say that Earth's magnetic field is pulling onto my leg, I don't know why I am not able to move. That is called gait apraxia. Gait apraxia, unable to clear the floor. That is usually seen in frontal lobe disease. So, but you are able to lift the foot, but not lift sufficiently, not moving forwards, but in the same side, you are lifting, putting down, lifting, putting down. That is called start hesitation. You are starting, but you are hesitant. That is extrapyramidal. Whereas magnetic gait is frontal lobe and start hesitation is extrapyramidal. Extrapyramidal disease, you lift, put down, lift, put down. So you have a static march, which we call it as a start hesitation.
Yes, ma'am.
These are the 2 things you have got in anti-gravity stretch. So once you have cleared the gravity, what do you do next? You have got stepping. You see, you have lifted your right leg. Let's just imagine this person's problem is in the right leg. So you
Yes,
have
ma'am.
lifted the right leg. After lifting the right leg, what should be he doing with the left leg?
Stabilizing, ma'am.
He planting the left leg on the floor.
Yes, ma'am.
He should not lift the left leg also.
Yes, ma'am.
He will fall down. So that is called stepping. Stepping is alternate flexion and extension of each leg is called stepping. So after you clear the gravity with one leg, you keep the opposite leg extended. And after that, you put the cleared foot forward and then try to flex the opposite leg. That is called stepping. So alternate flexion and extension takes place in the next part. So if the person is not able to step alternatively with both feet, what he will do? So first we saw the frontal lobe, they have got a glued to the floor. That is gait apraxia. Second, start hesitation, static march, like keep on lifting. That is extrapyramidal, I said. No? Next, now you have to put your foot forward. You are not able to put forward. You are neither able to step. So you are not able to alternatively flex and extend the one leg and the opposite leg in that particular fashion. That is carried out by the locomotor center, that rhythm, no? Most automatic of automatic movements, it is called. It's an automatic movement. If that is not happening, what will happen? You may either flex your both legs together or keep your both legs extended.
Yes, ma'am.
So if you flex your both legs together, you fall down. That is called pyramidal buckling. Pyramidal buckling. So in pyramidal tract disease, they will not be able to do the alternate stepping.
Yes, ma'am.
That's the second part. After clearing the gravity, you do stepping. That stepping is not possible. They may flex both feet together and fall down. That is called pyramidal buckling. If they are not flexing, what they will do?
Extension.
They cannot clear. So in the extended part, how they can move forward? They can move either by dragging themselves or by hopping. You see?
Yes, ma'am.
So these are the two methods. So when you say your patient is dragging, you said your patient is dragging, he is not clearing the floor, he is not doing alternate stepping, instead he is rubbing his feet along the floor. Like a patient in extension, he will drag. So dragging is a feature of pyramidal disease. So when there is a pyramidal disease, they will drag. Normal phenomenology of moving forward will not be there.
Yes, ma'am.
So when patient has no stepping, 2-3 things will happen. They will buckle and fall, or they will drag both legs, or by training, they will learn to hop and move forward. If you want to, so that's actually a training. It's called treadmill training. So these people are asked to run in the treadmill, and so to move, they are trained. If their stone is there, they can hop and move forward. That's a training. That's a gait training. So if the anti-gravity stretch is all right and stepping is abnormal, they will either drag or buckle or hop. So that is the second part. So in pyramidal disease, you drag. You drag means you do not clear the floor. This may be on one leg or both legs, depending on the disease, whether it is unilateral or bilateral. And third part is what? Balance. Supposing you have cleared the gravity and you have normal stepping, then you are going to move forward. For moving forward, you need balance. So third part of walking is balance. So anti-gravity stretch, then you are stepping, then you have got equilibrium. So that equilibrium is balance. If that is lost, even though patient is not dragging, he is not buckling, he is not hopping, he will sway to either side or he will reel to either side. He may sway if there is an anterior part of the cerebellum involved, and he will reel through a wide arc. If there is a flocculonodular lobe or inferior cerebellar peduncle, he will reel. So that is equilibrium. So a person with a loss of equilibrium can be affected by cerebellar disease vestibular disease or sensory system. These three things will produce imbalance. So cerebellar, anterior part of the cerebellum, they will gently sway. So that is called swaying. And if it is a posterior lobe of the cerebellum, it's a classical alcohol. So they will rotate through a very wide arc. That is called reeling. Swaying or reeling. And vestibular system and its connection, peripheral vestibular neuronitis, they also reel. They will have vertigo, vomiting and reeling. If there is a sensory thing, they will have a bizarre gait. They don't sway, they don't reel, but they will lift their feet too much. Because they do not know what is the distance between the floor and their legs unless they are looking at it. Proprioception is not there, so they don't know. So they will lift it up too much and then they will put it down also too much. So they will stamp. So sensory ataxia patients do not reel. They do not sway. They will tell that they have imbalance, but it will be a stamping. It will be a stamping gait. Then you have got next part, that is propulsion. So where do you drag? Pyramidal disease. Whether unilateral, bilateral. So if you tell the term dragging, it's an interpretation. So is it really dragging? Whatever patient says dragging is not dragging for us. So we should ask. As an undergraduate student, we should learn to ask, okay, sir, you are telling you are dragging. What exactly is happening? Tell me. Then you get the description from him. He cannot interpret, such a small child. And he do not know. And his mother also definitely will not know. They may tell any weak limb as a dragging limb. So we should not put it like that, even though history should be in the name of words of the patient, but not in the interpretation of the patient. Patient cannot interpret. No? So words of the patient means description, how he describes his walking. That you have to put. Then you have got the propulsion. Propulsion means moving forward. So when you are moving forward, you have got a pace. Pace is the distance covered between 2 feet for stable walking. So normal stable walking, you will move one hand forward and one leg forward and one leg backward, one hand backward. And there is a synkinetic movement of the arms. And you have got a pace. Normally, if you are neither running nor you are catwalking, normally there is a pace which is equal to the feet of the same patient. Stance and pace are usually equal. That is normal walking. So next, that is the pace. Pace is the distance covered between 2 feet for stable walking. So pace. Then turns. So how is he moving? Is he having the synkinetic arm swinging? Is one leg moving forward and other leg moving backward? And what is happening to the heel and the feet? Normally, the forward moving leg, the heel will touch the floor.
Yes, ma'am.
Heel will touch the floor. After the heel is touching, the toes will come down. If there is a foot drop, in the propulsion phase, instead of heel touching, the toes will touch.
Yes, ma'am.
So that will be in the propulsion phase. So in the propulsion phase, if there is no severe foot drop, the high stepping, all those things may not be there. Instead of heel strike, patient will have toe strike.
Yes.
This toe strike will make the toes get injured. So what is happening to the semiology? Is it heel strike or toe strike? Then to avoid toe strike, is the patient lifting too much? If it is very mild, they may not lift. You will have to tell the patient to stand on the heel and see. When he stands on the heel, he will not be able to stand on that side. That means it is a dorsiflexion weakness. So it is a changed semiology from heel strike to toe strike. So stance, pace. Then what is the semiology? Is it the heel strike? Is the arm swing all right? Is it alternating between both feet? Then is he swaying or reeling? Then what about the turns? So is he able to turn properly, or during the turns his imbalance is more? Usually patient will tell I am imbalanced when it is very mild. But you may not be able to observe much, very subtle. Then look at the turns. We do tandem walking turns. So subtle ataxia, there are several methods that you need not know as a small boy. No? So when he's turning, they will say, okay, I can walk level ground much better. But when I am turning, I am sure I will fall down. I am very careful. So turns is the situation where subtle imbalance will be brought out. So is he having imbalance during turns? So the stance, pace, turns. Then is it heel strike or toe strike? Then you have to see whether there is any buckling, any inversion of the foot, any dystonic posture. No? Then is there any hip dip? So normally what happens? The leg which is lifted up, the hip will go up.
Yes, ma'am.
If it is going down, you call it as a Trendelenburg effect.
Yes,
So that indicates proximal weakness is there. So one leg weakness may be anywhere. Patients will not be able to tell. So instead, during the propulsion phase, the hip is coming down. If the knee is buckling, it is quadriceps. If the hip is coming down, it is gluteus medius and minimus, the hip abductors.
Yes, ma'am.
If the heel is not striking and toe is striking, it is dorsiflexor. So during propulsion, each symptom will give you localization to one site. So that we have to ask.
Yes.
Then can he climb up, climb down? You told some problem in climbing up.
Yes, ma'am.
Next, so your patient is dragging, you told, but the dragging is the word told by the patient, I think so.
Yes,
So is it really that he is not at all clearing the floor and his limb is dragging with both heel and toe pulled along? Or is there anything else? So because patient cannot give you the interpretation. Patient can only give you the description. But what you told, I think it is the interpretation of the patient, you put it there.
Yes, ma'am.
Patient doesn't know, such a small child. And even the mother will not know. She may not be a medical person. Unless they are a medical person, they cannot. But they should describe. You should always tell them, don't tell me your disease. Patients will tell vertigo, vertigo. Finally, it may not be vertigo at all. And everybody will be giving vertigo medicines. Patient says vertigo, you say vertigo. Finally, it may be autonomic dysfunction, postural dizziness, or even seizures, or even stroke atom attacks. Everything they will tell vertigo. Then you ask whether there is really rotation. No. So when the patient says vertigo, we will not say vertigo. Even though it is insisted that put the history in the patient's own words. But own words, interpretation, no. Description.
Yes, ma'am.
So if he is dragging in the sense that we said now, then it is pyramidal disease. Not clearing the floor and putting both the heels and the toes together.
Yes, ma'am.
So that we will keep it abeyance, we will get the proper history. No? Next, is he able to climb up? You said there is problem in climbing up.
Yes, ma'am.
Then also you have to ask, what is the problem? You may have a pain. So first, as a small boy, you will not go straight to neurology. You are studying whole person. So you say, when you are climbing, do you have pain? That's the commonest cause, no? They may have pain in the ankle, they may have pain in the knee joint, they may have pain in the hips. We have picked up patients who have been suffering from Perthes disease. These small boys, they will fall down. They will have avascular necrosis of the femoral head. After that, the leg becomes short and wasted, and somebody will refer it as a neurological problem. Whereas it is a highly correctable orthopedic problem. So it's very relevant. You should tell him to describe. So when he is climbing up, is he having pain in any of these places? If there is no pain, what exactly is happening? Because climbing up involves lifting one foot, putting it on the step above. For putting it on the step above, you have got several agonists. Agonist is the hip flexor. The hip has to flex. If the hip flexor is weak, he cannot put it on the step above. So he will hold his leg with a hand and put it on the step above.
Yes, ma'am.
That is one climbing. After putting your leg on the step above, you have to lift your trunk.
Yes, ma'am.
So to lift your trunk, you need hip extensor.
Yes, ma'am.
So if the hip extensor is weak, then also you cannot climb. That's the next part. You will not be lifting your leg with your hand. Instead, you will put it, but your hip will not go up. The hip will dip. Hip extensor is weak, hip will come down. So you hold on to some side and you flex your trunk and then try to get up. That is hip extensor. If
Yes,
hip
ma'am.
abductor is weak also, you will have difficulty, you will fall down. You will have waddling, exaggerated waddling. So
Waddling.
when you are climbing up, if you are landing on your knee, you are buckling.
Yes, ma'am.
Or when you are climbing up, your toes are getting injured. You are having dorsiflexion weakness.
Okay.
Climbing up difficulty, you should split into its subcomponents, knowing the
Yes, ma'am.
muscles that are involved in the acts of climbing, and ask what is happening. Always
Yes, ma'am.
ask non-neurological causes if that function involves other systems.
Yes,
You
ma'am.
should always ask, because patient will not know the specialty to which he will have to go. It's our duty to direct them. So
Yes, ma'am.
ask them about other system, that is the pain. Then what semiology interfered with this climbing up. Just climbing up, we don't know. You see, you have to tell all the step by step. Then we know where is the problem. So this patient has got climbing up problem. I hope that it is not painful. In that case, we can say it is not due to bones or ligaments. But why is he not climbing up? We cannot discuss at this point, because we have not got the fine components of climbing difficulty, which just now I told you. So that
Yes,
we will
ma'am.
keep it. Next time when you see, because you are small boy, I know, I am telling you how to ask a history. Sometimes
ma'am.
they won't describe at all. I know that you are small boy only, but when you go into life, you will know that they will never describe. They will beat around the bush, tell everything about prescriptions and all those things, but you have to tell them. So forget about all those things. I do not understand that language. Tell me what exactly happens. What do you do when you are climbing up? Then they will tell, I am lifting my leg with my hand. Otherwise, I cannot put it on the step above. Straightforward answer is over. It is hip flexor. Or you will say, my toe is always getting injured on the while climbing. So I'll have to lift my leg too much and then put it up. Then, you know, it's foot drop.
Yes, ma'am.
So like that.
Ma'am, he mentioned he is unable to lift the foot sufficiently while climbing the stairs, ma'am.
So it is not proximal part.
No, not the proximal part, ma'am, distal part.
So then that you should tell. Then probably patient has got a distal weakness. So like that, in the initial walking also, it may not be dragging. If
Yes,
there is
ma'am.
drop, it may not be dragging. It is the
Yes,
toe strike. So it's a semiology change from the heel strike to toe strike.
yes, ma'am.
Then it is
Ma'am,
totally
he mentioned
different.
he's like he feels like tripping because of he's unable to lift the leg feet sufficiently up. He trips more often.
Then the answer is, it is not dragging.
Yes, ma'am.
It is semiology change to toe first. So
Yes,
he is
ma'am.
tearing the toes and tripping. So it's a
Yes, ma'am.
dorsiflexor weakness.
Yes,
So we
ma'am.
will not use that word dragging. It
Yes,
is a
ma'am.
tripping due to changed semiology.
Yes, ma'am.
So that's only, so it is dorsiflexor weakness.
Yes, ma'am.
So that we, apparently, if this history is revised.
Yes, ma'am.
Then after climbing up, what happens, you told? No
Ma'am,
buckling. Can you climb
no
down?
buckling is there. Yes, ma'am. He can climb, but there is he is able to climb with difficulty, ma'am. He need extra, like I'm unable to explain it completely.
Well, is climbing down also the same dorsiflexion
No, ma'am.
weakness
He
will
is
be
able to
interfered?
climb down normally, ma'am. He is able to climb down normally.
Okay. Is the limb flail or stiff?
Ma'am, flail, not stiff, ma'am,
Flail.
not stiff.
Because dorsiflexion weakness can be pyramidal foot drop
Yes,
or
ma'am.
can be lower motor neuron foot drop. So now from your history, you have told that there is no sensory symptom, there is no
Yes,
autonomic symptom, there is a one leg weakness, and that
yes,
one
ma'am.
leg weakness is a flail limb.
Yes,
It is
ma'am.
not a stiff limb. So it's
Yes,
a
ma'am.
lower motor neuron type of foot drop.
Foot drop.
That's what your patient is having. So
Yes, ma'am.
as an undergraduate student, what you should learn, how to differentiate upper motor neuron from lower. Because pyramidal tract also will produce foot drop. I'm sure
Yes,
you
ma'am.
might have seen hemiplegic patients.
Yes, ma'am.
They have a pyramidal involvement. They have
ma'am.
foot drop, they circumduct, and they have a toe first semiology. No.
Yes, ma'am.
So that is a pyramidal foot drop. So just
ma'am.
at this point, a learning for an undergraduate student will be what are all the points by which you differentiate upper motor neuron from lower motor neuron. So pure motor syndrome, no autonomic, no sensory you have to. So pure
Yes, ma'am.
motor, how to differentiate upper motor from lower motor.
Ma'am, spasticity is seen in upper motor.
Very good.
Upper motor. Yes, ma'am.
So in upper motor neuron disease, there is hypertonia.
Hypertonia.
Whereas in lower motor neuron disease, there is hypotonia. Agreed.
Hyperreflexia in upper motor and hyporeflexia in lower motor.
Oh, yes. What else would you like to tell about reflexes?
Ma'am, hyporeflexes in lower motor neuron, hyperreflexia in upper motor.
What more? You have to tell that superficial reflexes are lost.
Yes, ma'am.
Deep reflexes are exaggerated in
Yes,
upper motor neuron. In upper motor neuron disease, superficial reflex, for example, abdominal reflex, that is lost. But deep reflexes are exaggerated.
Yes, ma'am.
Whereas in lower motor neuron, both superficial and deep reflexes are lost. So
Yes,
it is not that all are similarly involved. In upper motor neuron, superficial is lost, deep is exaggerated. Whereas in lower motor neuron, both superficial and deep is lost. So that is the second. What is third point? Where you get wasting?
Ma'am, lower motor neuron we'll get wasting, whereas in upper motor neuron,
what do you get?
Yes.
You do not get wasting, but if the upper motor neuron disease persists for a long time. For example, if you have seen a child with infantile hemiplegia, child would have hemiplegia at the age of 3 or 4, no? There will be no wasting, but that part of the body will be smaller.
Yes, ma'am.
So that is called hypoplasia.
Yes, ma'am.
Hypoplasia. So in upper motor neuron, when it is chronic, there is uniform decrease in the size of that body part. That is called hypoplasia.
Yes,
whereas in LMN, you get wasting, increased growth, loss of muscle bulk and all those things. What is the fourth point?
Fasciculations, etc. will be seen in lower motor.
There is no fasciculation in the upper motor neuron. Fifth point. What is clonus?
Hyperreflexia, sustained reflex.
Sustained stretch will produce repetitive motor movement. So in an upper motor neuron disease, you get clonus. Whereas in lower motor neuron disease, you can get fasciculations and fibrillations. You don't get clonus. Next, what about the plantar response?
Plantar will be
upgoing, depending on the state of involvement. Upgoing in the upper motor neuron disease. Yes. Whereas it is of no response, depending on the muscles that are affected. If the AHL is affected, it will not go up. And if the big toe flexors are affected, it will not flex, but it will not be an extensor response. That is lower motor neuron.
Ma'am, a small doubt, is a triple response a part of the Babinski, or is it different, ma'am?
It is part of the Babinski response only.
Yes, ma'am. Next
point, what are these pandiculations? You heard of pandiculations?
No.
It is one patient is saying that he is not able to move one leg. You are not getting enough signs. And when you are moving to the opposite room, you see that he lifted that limb which he did not move. And at that time, if you have noticed, he yawned. So that is called pandiculation, because in upper motor neuron disease, there is no muscle paralysis. There is only movement paralysis by one mode. So voluntarily, patient cannot move. Reflexly, he can move. That is why deep reflexes are exaggerated. So reflex movement. Similarly, when he is yawning, or if he suddenly sees a snake, or somebody suddenly calls him, the paralyzed limb stiffly move. That is called pandiculations. This never happens in LMN. So these are the 7 points to differentiate upper motor neuron from lower motor. Apparently, your patient's leg is flail, so it's a lower motor neuron disease. So is it an acute onset, subacute onset, slowly progressive, dorsiflexor weakness, and history-wise there is no sensory?
Yes, ma'am.
Or autonomic. However, you told about the injections and so many things. No? So
Yes,
what
ma'am.
are the situations where you get a foot drop and how do you differentiate? Because you have straight away put HMS and muscular dystrophy. That should not be the diagnosis of a small boy like you, no? You should not be carried away by whatever you got by investigations can be wrong, but you
Yes,
will
ma'am.
not be wrong. Because you cannot be wrong and you should not be wrong. No? So for such an asymmetrical disease, you should not diagnose all these things. No? So now we will go through the structures which can produce a foot drop. That's all we have got now, only foot drop.
Yes, ma'am.
So from the
Yes,
history,
ma'am.
nobody can diagnose muscular dystrophy and all those things. No?
Yes,
So foot drop, what are the situations? So dorsiflexor can be weak due to nerve involvement or due to
Left.
root involvement,
Root.
or due to plexus involvement,
Yes.
or due to anterior console involvement, or upper motor neuron, which we just now finished off. Pyramidal foot drop, what are all the points we thought about, or it could be even a cortical monoparesis. When the leg
Yes,
area, where is the leg area in the cortex?
ma'am, in the medial part of the...
Very good, wonderful. So you're a very good student. I understand you're a very good student. So it can be monoparesis from the cortex up to the peripheral lower motor neuron.
Yes, ma'am.
So would you like to tell me, supposing there is a weak paralysis of the injection policy, you told, no?
Yes,
So
ma'am.
it is for a undergraduate student, good undergraduate student. What will be the manifestation if the sciatic nerve is involved?
Ma'am,
That's what
sciatic pain along the distribution of the sciatic nerve.
very good. So, and you may have a tinal sign.
Yes, ma'am. Tinal sign.
Tinal
Yes, ma'am.
sign, you tap the nerve, the patient will have pain. That is, so there can be pain along the sciatic nerve and tinal sign. Agreed. Second point. Sensory, motor, reflex, like the title. Anything, you use 3 parameters. Sensory distribution, motor distribution, and reflex changes, and anything unusual. That also will add. No? So sensory, what is the supply of sciatic nerve?
Ma'am, dorsum of the foot.
Sciatic nerve supplies whole of the leg.
Yes, ma'am.
Except
Yes,
the
ma'am.
medial part of the leg, which is supplied by the saphenous nerve.
Yes,
So
yes, ma'am.
sciatic nerve supplies the whole of the leg, everywhere. Dorsal
Yes, ma'am.
aspect, plantar aspect, lateral aspect, everything. Only
Yes,
a
ma'am.
small medial strip is supplied by the
Saphenous nerve.
saphenous. So sciatic nerve sensory, you should know injection policies, primary health centers, all these things, it can happen. Medical legal importance is there. So it will produce sensory loss in the whole of the leg except the medial part supplied by the saphenous nerve. Second, motor.
Motor.
It supplies all the muscles of the legs.
Yes, ma'am.
Dorsiflexor, plantar flexors, inverters, everters, everything. In addition, what other muscle? In the upper part of the leg, which muscle is supplied? Hamstrings. Semi-tendinosus, semi-membranosus, and long head of bicep. So all the muscles of the leg will be involved to varying degree depending on how much injection has been injected into the nerve. And hamstrings. So sciatic nerve supplies all the muscles of the leg as well as hamstrings. Is there any reflex carried by the sciatic nerve? Angle jerk.
Ankle jerk, yes, ma'am.
So angle jerk will be lost. So sciatic nerve injection policy will be like this. Next, we will come to the division of the sciatic nerve into superficial peroneal, deep peroneal. So deep peroneal, what is sensory, what is motor, what is reflex? First interdigital space is sensory.
Sensory, yes, ma'am.
Web space. So deep peroneal nerve, first web space is sensory.
Yes,
then what is the motor?
Ma'am, the
it supplies tibialis anterior.
Yes, ma'am, extensor distorum brevis. Extensor digitorum longus. Ma'am,
Tibialis anterior.
yes, tibialis anterior. Yes, ma'am.
Yes. Then what about the common peroneal nerve? No reflex. There is no reflex for the deep peroneal. What is the common peroneal nerve? Common peroneal nerve has got a cutaneous sensory supply by a cutaneous branch in the neck of the fibula around.
Yes, ma'am.
That is the nerve which is commonly involved in Hansen's disease. Then it supplies the lateral part of the leg through the superficial peroneal nerve. Superficial peroneal branch of the common peroneal nerve. So there is a circumferential patch in the neck of the fibula, which is a purely cutaneous sensory branch. And then you have got a superficial peroneal branch which supplies the lateral part of the leg in between the, it is anterior to the territory of the sural nerve.
Yes, ma'am.
Sural nerve is supplying little more behind. So it is along the lateral part of the leg up to the lateral malleolus. So that is the patch along the neck of the fibula and a long strip up to the lateral malleolus is sensory. Motor is all the dorsiflexors. Plus, it can supply the peroneal group of muscles. But the plantar flexors are spared. So there is branch of the sciatic nerve involvement. Angle jerk will be not affected.
Yes, ma'am.
So angle jerk will be normal. Commonly, common peroneal nerve we injured by sitting for mridangam or something like that. Several hours you play a musical instrument or you travel in a very crowded bus, or olden days when we are all small, some marriage and all, it may not be experience for you. Cars and all used to be very speciality, very luxury. So when there is a marriage, 100 people will be pushed, jammed in the what is olden times on car used to be there. What is a big car? I forgot the name. Which one?
Ambassador.
Correct. Ambassador car. So it will be packed, and at the end of 1 hour, you may have a foot drop. So that is pressure palsies and Hansen's disease. No, commonly involve the cutaneous branch around the neck of the fibula and common peroneal. So it will produce foot drop with the spade angle jerk. So that is the branches of the sciatic nerve. So next we will go to the root. So dorsiflexors are supplied by which root?
Ma'am, L5.
Yes, very good. L5 root. So what is the sensory supply of L? Sensory motor reflex. Like that I told, no? What is the sensory supply of L5? You are very good, ma. For when we were undergraduate, I am not sure I can answer like this. You are answering very well. So be very confident. I know you are a small boy, no? So sensory impairment is along the lateral part of the leg, across the angle to the big toe. So it's a oblique sensory supply.
Yes, ma'am.
It's a lateral part of the leg. So no psychogenic patient can imitate this because they don't know this goes like this. So it's the lateral part of the leg across the angle to the base of the big toe. That is sensory. Then motor will be extensor hallucis longus, extensor digitorum longus, tibialis anterior, extensor digitorum bruis.
Yes, ma'am.
Then you have got no reflex. And the pain will be a root pain. It will be a shock-like pain. For the nerve told tinal sign and a tenderness along the distribution of the nerve. Whereas for the root, it will be a shock-like pain. It will be intermittent. And it will have definite precipitating factor, coughing, sneezing, bending, weightlifting. Supposing this boy had a disc, very unusual small boy, but let us imagine, or anything else in the L5 root. So if it is a radiculopathy, root pains, and sensory is along the lateral part of the leg across the angle to the big toe, and dorsiflexors are weak, and there is no reflex. That is L5 root. Next, we will go to the in-between structure, that is plexus. We thought about the nerves, no? Normally, one plexus will give to several nerves. You know that. Lumbosacral plexus will give to several nerves. It will give to operator nerve, femoral nerve, sciatic nerve. So every plexus gives rise to several nerves. So pain will be in the location of the plexus. So supposing there is a lumbosacral plexus involvement, due to whatever cause. Children can get plexopathy due to various causes. So if that plexopathy is there, patient will have a pain in the iliac fossa. So you might think it is appendicitis or diverticulitis. So surgeon takes the patient to the theater and does the appendicectomy. In the post-operative period, patient develops a paralysis and they will sue the doctor. Actually, it must have been a plexopathy which was evolving and surgeon mistook it as an appendicitis. These things have happened in the medical college, which I have seen. So the location of the plexus, the pain will be in the location of the plexus, which can be mixed for upper limb, can be mixed for myocardial infarction, aortic dissection, or in the lower limbs, it can be diverticulitis or appendicitis.
Yes, ma'am.
And it will spread along multiple nerves because as told from the plexus, multiple nerves come. So it could be a combination of sciatic nerve and obturator nerve, or sciatic nerve and femoral nerve. Then you will say, okay, my patient is developing a plexopathy. Small children, hemophilics, they can bleed into the plexus. No? They can have traumatic avulsions, or they can have plexopathy following vaccination due to demyelination, or some kind of neuropathies are there, hereditary neuropathy with tendency for pressure palsy. Those people have, when they are very small, plexus involvement. No? So plexus means location of the plexus, there is pain, which is a great imitator, and the transmission is along more than one nerve that comes from that plexus. So that is plexus. Next, we said we will go to the anterior horn. So all these are sensory and motor.
Yes, ma'am.
Your patient is only motor.
Yes, ma'am.
That it is purely motor. No?
Purely.
So you will have to feel that probably this is not my patient's condition.
Yes,
because he is totally denying any sensory, either positive or negative. Neither root pains nor numbness. So neither the positive is there nor the negative is there. So all these nerves, roots, plexus are probably less likely. There are pure motor neuropathies, pure motor radiculopathies are all there. They are exceptions than examples. So we will think these are less likely. So we will go to the anterior console. At the level of the anterior console, in a children, what do you call this group of disorders?
Motor neuron disease.
Always we should think in a very broad way. Then only build acute flaccid paralysis. This is an 11-year-old child, no? Is he suffering from an anterior console disease, acute or subacute? Acute, only 6 months it is. So you could have had an acute illness which is going on to a secondary change like wasting and bulk loss. So is it an acute flaccid paralysis? So you have got an anterior console pattern. So again take sensory motor reflex. There is no sensory. For anterior console, there is no sensory. And reflexes depending on etiology. If it is due to acute viral illness, it will be lost. If it is due to a degenerative disease like a focal motor neuron disease, it can be retained. No? So that is reflex. Reflexes can be lost if it is a polio or polio-like illness, or if it is a degenerative condition where motor neurons are degenerating, reflexes can be retained. Then you have got the next question. Acute flaccid paralysis is a question for undergraduates, I think, because polio has been reported eradicated, and it is still you have to report this condition.
Yes, ma'am.
Acute flaccid paralysis. You have to talk about Guillain-Barré syndrome. You have to talk about polio, and you have to talk about focal anterior disease of focal varieties like wasted leg syndromes. All these you have to tell. Yes. So now Guillain-Barré syndrome, what will be the manifestation? Sensory motor reflex.
Ma'am, glove stock like pattern of.
No need for glove stock. Guillain-Barré can be sometimes focal, not always like the proximal more than distal weakness will be there. So there is a thing called focal Guillain-Barré. So there will be an acute onset of weakness. More than one nerve should be involved, areflexic. And when you check sensations are not there in the history, but when you examine, you will find the large sensory fibers, proprioceptive fibers will show deficit. So areflexia, more than one nerve distribution and proprioception involvement, and duration of progression is Usually onset to peak is about 2 to 3 weeks, but it can go on till 3 months. Sometimes it can go on till 3 months. Rare varieties. So that is acute Guillain-Barré. Second, acute polio. Polio, what is the pattern called? It is column pattern. We call it as column pattern. You see?
Yes, ma'am.
Polio, of course, history. You can have a preceding diarrheal illness. You could have had a mild febrile disease. And it is a meningitis. Actually, it is a meningitis. So patient will have irritability, some neck stiffness, Karnic sign may be there, not always. You can get it. And the pain, patient will have painful paralysis, but no sensory. Patient will have pain limitation of movement. No? And then you have areflexia. And you have no proprioception, no sensory loss. But the pattern of polio is called column pattern. Short column and long column muscles are there. Supposing you take L5. L5 is supplying extensor hallucis longus, extensor digitorum longus, extensor digitorum brevis, gluteus medius, gluteus minimus. So many muscles. They are long column. Whereas short column muscles, if you take S2, it is supplying only the short muscles and the hamstrings. So short column muscles, when they are involved, they will be severely paralyzed.
Yes, ma'am.
Because the segment of the anterior console will be destroyed by poliovirus. Whereas it's a long column muscle that is spreading over several segments. They are commonly involved, but the weakness is less. That is called column pattern. So long column muscles are involved, but they are not totally paralyzed. Whereas short column muscles, when they are involved, they are severely paralyzed because they are having a short segment which will be destroyed by the virus. So that is called a column pattern. Whereas if it is a degenerative anterior console disease, what is that pattern? It is so different. It is called selection within an anterior console because it is a motor unit that is degenerating, not a segment of ventral horns. A segment of ventral horns are not degenerating, like a polio. Whereas one neuron in the ventral horn is getting sick. We call it as Mecoma sick motor neuron theory. So one motor unit that is applied by a motor neuron and its efferents get sick. So if you take a extensor hallucis, L5 innervated muscles, let us take, no? You will find that extensor hallucis longus is very weak, but extensor digitorum longus is very good. That is called selection within a territory. Because it is not a root or a whole of anterior console. It is a motor unit. Motor unit is within the ventral horn, some cells are getting sick. You tell finger drop, toe drop, no? Even though all the toes are getting the same supply, 3 toes will be normal and 1 toe will drop. That is anterior console pattern. So anterior console pattern is selection within a segment. One will be very much involved and one will be very less involved. So this could be at the level of the anterior console. That is one possibility if this is LMN, because it is purely motor. Purely motor, single limb weakness can be at the level of the anterior console. What do you call that? If it is not acute, if it is acute, polio-like illness. You have got Epstein-Barr virus, Coxsackie virus. They can present like a polio. No? So they are all viral diseases. Then you have got a degenerate. They are acute, initially paralyzed, painful, cellular CSF, and then they settle down and they go into wasting and contracture. Whereas if it is a motor neuron disease, Chopra's wasted leg syndrome, it is described by Dr. Chopra from PGI. First case, we call it as wasted leg syndrome. So those patients slowly start and steadily progress. So that will start with the motor unit involvement, not respecting a nerve or a root. Slowly progress. They will have wasting, fasciculations. Their reflexes can be retained in the early stage, and when all the motor neurons are knocked out, they will be lost. So for an element, pure motor, slowly progressive condition, where is the location? Are you going to locate it in the ventral horns. That's a very much possibility.
Yes,
One possibility. No? Next, is it in the upper motor neuron? You can have a partial pyramidal tract disease, chemisectioning lesions of the spinal cord. Or you can have parasitical lesions, where it will be a spastic. It will be pyramidal foot drop. So that is what, but you said that your limb is flail. So here you cannot at this point think of a hereditary neuropathy. From this history, it may be bilateral, but patient may be telling unilateral. But with unilateral history, you cannot diagnose a hereditary motor neuropathies. They are symmetrical diseases, mild asymmetry can be there. Patient, what the patient says is his feeling. But when you examine, what you have to tell. So supposing it's a pure motor nerve. Now I told you how to differentiate an acute androhonsal due to viral diseases from a chronic androhonsal disease due to degenerative disease. Next, I told you about various mononeuritis. Let us see motor nerves. So when do you say when it is a motor nerve or a muscle or a myoneural junction? You have to differentiate, no? So suppose you have got a distal myopathy. They are all symmetrical diseases, first of all. Because you have put symmetrical diagnosis as the first possibility. That is because you have not analyzed it that way. That's okay because you see your diagnosis can be wrong. But no problem. But your approach should be correct. If your approach is correct, 99% of the time you will be correct. 1% you may go wrong. But you should never lose your approach. And straight away, put a diagnosis based on your genetics. That we call it as cutting the head to fit the cap. You should not cut the head and fit the cap. Why will be a neuropathy, hereditary neuropathy in one leg? It will not happen, you see. It doesn't happen also. That is a history. History may be wrong. And as you know, he's a very small child. So you don't know what he thought. Or it may be entirely different disease. Genetics can go wrong. Many times we get funny genetic results. So, so those things and all, you should not try to fit and think that there is 100% sensitivity for some test. No. 100% sensitivity is for your sincerity only.
Yes, ma'am.
Okay, ma'am. So, next I'll ask you, what distal muscle? Let us imagine my patient has got a distal myopathy, or my patient has got a congenital myasthenia, or they are all motor syndromes, or my patient has got a hereditary or acquired motor neuropathy. What will be your clue? That is called pattern recognition.
Let
us imagine I tell this boy is having distal myopathy. What are all the points for and points against? Asymmetry is the points against all this. That we will keep apart. We will say it is symmetrical. Let us imagine, no? So I'm asking you how to differentiate muscle, myoneural junction, and motor nerves.
Yes, ma'am. Myopathy mostly proximal, but in this case,
there
it can be
myopathies, no? Distal myopathy.
Yes, distal myopathy, yes, ma'am. And neuromuscular junction, it is
how do you differentiate muscle from motor nerves? That is the point I asked you.
Yes, ma'am.
Because neurology is still clinical.
Yes, ma'am.
Unlike nephrology or cardiology and other subjects where you need not see the patient, you take the laboratory, provided your lab is a reliable lab, no? Whereas neurology is still clinical subject. It's very vast subject. If you miss the clinical, you will find incidental lesions and end up treating a incidental lesion which has nothing to do with the patient, no? So you should tell me, is nerves or length-dependent involvement? Nerves length-dependent involvement. So you will never have a motor neuropathy which is pairing the distalmost muscles like the interossei and picking up the dorsiflexors. So suppose you have got a motor neuropathy, a symmetrical motor neuropathy, the distalmost muscles will be the worst affected because it depends on the nutrition flow, axoplasmic flow. Whereas muscle diseases have something called selectivity, depending on the cytoskeleton. Each muscle disease has got a wide variety of proteins. So each disease got a different protein, dystrophinopathy, sarcoglycanopathy, different proteins. So that cytoskeleton determines the involvement. So it has nothing to do with the axoplasmic flow. So motor neuropathies, when they are symmetrical motor neuropathies, not mononeuritis multiplex, they will affect the distal most muscles.
Yes, ma'am.
They will not spare the distal muscles and pick up a proximal muscle. Whereas myopathies, distal myopathies, depending on the distribution of the cytoskeleton, they have selectivity. So they can spare the distalmost muscle and involve the proximal anterior horn cell. We have got muscles called nonega, myoshi. I am sure you are not expected to talk about all those things. You are small boy only, but muscle show what is called selectivity depending on the cytoskeleton and the protein that is involved and that is distributed. So it need not involve the distal most worst and pick up the muscle based on the cytosine. So muscle diseases have got a selectivity pattern, whereas nerve disease, symmetrical motor neuropathy, will be having length dependent pattern. It will become the distal most and then come proximally. No? What about bioneural junction?
Ma'am, it progresses from morning to evening. It is worse in the evening compared to the.
So demonstrable fatigability. Congenital myasthenias can involve the distal muscles also. Unlike the adult myasthenia, which involves ocular muscles, bulbar muscles, and proximal muscles more in an asymmetrical fashion. Congenital myasthenias are little different. They can involve distal, proximal, focal, lower limb, sparing the cranial bulbar, all that can happen. But the typical feature is exertion-induced demonstrable loss in the power.
Yes, ma'am.
So now we have analyzed all the motor causes. So that starts from the anterior horn cell, acute, chronic. Second, we thought about the motor neuropathies. We thought about muscle diseases, and we have thought about myoneural junction disease. So this becomes the DD when the sensory is not there. But when it is asymmetrical, many of them get negated. If this history is correct, that is having only one side and all his milestones are normal, how you cannot diagnose a symmetrical condition as the first possibility. So here you will keep a first possibility, believing this child and his mother's history as correct. It can be so much wrong. Many times can be so much wrong. When we examine, you might find different features. Maybe, I don't know. But if it is asymmetrical, my first diagnosis will be a focal variety of Anderson disease like a monomelic atrophy. Purely motor, element syndrome, progressive, and not an acute onset, subacute onset. So, if that history is correct, all your muscular dystrophies, all those things, you should not tell only.
Yes, ma'am.
So you should be true to what you obtain.
Yes, ma'am.
From the history. It's a history diagnosis.
Yes, ma'am.
History can be wrong. So if the history is wrong, your history diagnosis will be wrong. But you have to explain why you are telling. If you tell muscular dystrophy for a purely progressive foot drop in a one leg, you will never diagnose muscular dystrophy. There is no such muscular dystrophy. There is no motor neuropathy. There is nothing like that. What is the inherited motor? You told inherited and all. What is the inherited motor neuropathy which can be asymmetrical? And how does it present? There is something called hereditary neuropathy with tendency for pressure palsy.
Yes, ma'am. Yes, ma'am.
Because they have got a bulky nerve with onion bulbs. Many members in the family will have. They may not have any weakness in the routine setting. But when they press on that, they develop. When they sit in a crowded bus or ambassador car or do mridangam.
Yes, ma'am.
So HNPP is the only condition where a hereditary neuropathy can have an asymmetrical, so much asymmetrical. They will develop foot drop. It will be sensory motor. It will have sensory and motor. And they improve with steroids like any other pressure palsy. And then again get. So when they are getting even mild pressure, if they are getting, you examine, it's a dominantly inherited condition. You can do the genetics if you are in such a situation, or you can check the nerve conduction in the father and the mother. Usually any one of them will show subclinical abnormality resembling HNPP. So HNPP is the only hereditary neuropathy which can be that much asymmetrical. So for such an asymmetrical or purely one limb, you should never put all those diagnoses which you have put. Okay, if this history, after examination, what you found, we will discuss accordingly.
Yes, ma'am.
I'm just telling you how to approach. That's what you should learn. Diagnosis, forget about that, no? So then now go to examination. You told elaborate history, but what we tell for the history, supposing there is one limb motor, that is the symptom that person has told. Your history
Yes, ma'am.
should elaborate motor on the other body parts
Yes, ma'am.
by leading questions. Then whether that motor can be due to amyloidosis, whether that motor can be due to porphyria, can
Okay,
it
yes, ma'am.
retina? So extend your diagnosis. So that motor which is related to other conditions. So you
Yes,
see,
ma'am.
have Addisonian feature, adrenomyeloneuropathies, no? So
Yes,
like
ma'am.
that, you build the history. You don't have to tell all the histories applicable to most of the diseases in the neuroaxis for a symptom which is not likely to be related.
Yes, ma'am.
So you can tell about autonomic sensory, that all agreed, optic nerve, eighth nerve, you know.
Yes, ma'am.
Other fatigability, all those symptoms you should tell, craniobulbar, occasional litosis, was it there or not? And so expand on that symptom which the patient has given. So subjectively, one limb is experienced. What about the other limbs? And what about the related symptoms of that weakness? And what all
Yes,
the
ma'am.
other systemic diseases which can present like that? So
Yes,
does he
ma'am.
have some visceromegaly? Anytime did he have an abnormal color of the urine?
Yes, ma'am.
As he become more pigmented than his parents, no? So that kind
Yes,
of
ma'am.
history, if you tell, that you are knowing little bit of theory also about these
Yes, ma'am.
conditions, you will think. You are doing very well for a small boy, ma, but I am just telling you how to approach. Understand? You have presented
Yes, ma'am.
very well only. It's a very wonderful presentation for your final year MBBS. I am sure I don't know to present like this when I was an undergraduate student. I am sure of that. So doing very well, excellent. So now go to your examination.
Ma'am, one doubt. Like why myasthenia gravis is like first affects the orbicular eye muscles.
Because you see, it depends on the energy demand.
Yes,
It's
ma'am.
the energy failure, petrol failure, no?
Yes, ma'am.
Acetylcholine is less. So you see, you are always keeping your eyeball muscles continuously active.
Okay, yes, ma'am.
The most active muscle fails.
Yes, ma'am.
That is why it is the ocular bulbar muscles which fail early, and
Yes, ma'am.
bulky muscles, that's why proximal muscles. But you have got other variants, musk variant,
Yes, ma'am.
and other,
Yes,
you have got paraneoplastic myasthenia,
yes, ma'am.
and you have got limb onset myasthenia. They are due to various distribution of the antibodies.
Yes, ma'am.
Musk antibody syndromes, they do not produce ocular bulbar much. Instead, they affect the tongue.
Yes, ma'am.
Tongue can also become wasted. So that is depending on the type of antibody. But why myasthenia? Commonly, classical myasthenia pick up the ocular muscles because it is always working.
Yes,
So,
ma'am.
muscle. Okay.
Thank you.
Good. Go on. Examination.
Yes, ma'am.
History over. I will
Yes,
not
ma'am.
think of all those diagnoses which you have put there.
Yes, ma'am.
Okay.
Yes, ma'am. Then coming to the child is thinly built. He is conscious, cooperative, well oriented to time, place, and person. His anthropometric measurements are his height is 134 centimeters, weight is 25 kilograms, head circumference is 54 centimeters, and vitals are pulse is 88 per minute, blood pressure 126 by 80 mm of Hg in sitting position, respiratory rate is 20 beats per minute, temperature 98.6 degrees Fahrenheit, and oxygen saturation is 100% on room air. Pallor, icterus, cyanosis, clubbing, lymphadenopathy, and peripheral edema are absent. Ma'am, on examination, bilateral pes cavus present, muscular atrophy in the lower leg causing inverted champagne bottle appearance present. There is no signs of angular scleritis, glossitis, knuckle hyperpigmentation.
So
No
bilateral
target.
pes. What do you mean by pes, ma?
Ma'am, high arched.
You should only describe. You are a small boy, no?
Yes,
You should let
yes,
it describe. You should say that my patient's medial arch is larger than the lateral arch. And ball of the big toe is slightly on touching the plantar foot floor much more than the toes.
Yes, ma'am.
And when he plants his foot on the floor, the medial part is not producing an impression. And when he is hanging his leg free, the pes cavus is best demonstrated by making the patient sit and hang the legs free.
Yes, ma'am.
You feel that the medial arch is much more. Then you have got methods to calculate the medial arch. That is okay. That is you need not do. It is only bedside examination. So because of that, I feel there is a pes cavus.
Yes, ma'am.
Like that, you should describe when you examine. You describe that foot. This is the time to learn to describe. And
Yes,
when you
ma'am.
become postgraduate, you will describe at a different level. Then you become neurologist, let's go on different level. And then when you become a consultant, you can straight away say pes cavus. No?
Yes,
So, but now you should learn describing. So
Yes,
the
ma'am.
medial arch is more agreed. Pes cavus is there. What does that mean? Is that pes cavus correctable? Is it pes cavus correctable means when he stands on the floor, is it flattening? Or is it remaining? Or can you mechanically correct it? Yes, pes
Yes.
cavus can be due to skeletal structure involvement also.
Yes, ma'am.
In which case you cannot correct it.
Yes, ma'am.
It is due to nerve or muscle involvement. When he stands, it will become flat.
Yes, ma'am.
He has got an increased medial arch. Ball of the big toe is touching the floor. More prominent one hanging the feet. And that I am able to mechanically correct.
Yes, ma'am.
In that case, you know it is not orthopedic.
Yes, ma'am.
It is not a bony one. If it is not correctable, it is bony.
Yes, ma'am.
Now it is bilateral. You see, history
Bilateral, yes, ma'am.
diagnosis should be not on examination, on history only. No?
Yes,
So
ma'am.
you have examined and you found it bilateral. That's a different thing.
Yes, ma'am.
So there is a bilateral pes cavus. So bilateral pes cavus with what about the power of the small muscles? You are only describing the pes cavus, no? Okay.
Yes, ma'am.
So instead of telling pes cavus, you should describe. No?
Yes,
Then
ma'am.
you should tell, is it correctable or not correctable? When you're planting the foot, is it correctable or not correctable? That will tell us, is it orthopedic or neuromuscular?
Yes,
If
ma'am.
it is correctable, it is neuromuscular, not orthopedic. So
Yes, ma'am.
then you have got atrophy.
Yes, ma'am.
The lower leg. Need not go and tell inverted champagne for bottle and all. You see,
Yes, ma'am.
that's okay. You can say that there is wasting of them. What is the anterior compartment? What is the posterior compartment? What is the lateral compartment? Like that you have to describe, no?
Yes, ma'am.
Which compartment is worst affected and what about the thigh muscles? You can say thigh
Yes,
muscles are better preserved
Yes, ma'am.
than the leg muscles.
Yes,
And in the leg, is the lateral compartment more affected or are they all uniformly affected?
Yes, ma'am.
So like that you tell. Champagne,
Yes, ma'am.
let it be there. We are not, we are Indians now. We don't want
Yes,
champagne. No?
Yes.
So we will tell what is the group that is how you should learn to describe. Yeah,
Yes, ma'am.
when you're small, no, you get very happy to use some fashionable terms. That
Yes, ma'am.
doesn't mean anything for us, no?
Yes,
If you pick up the compartment that is wasted, your brain will be working.
Yes, ma'am.
So is it the lateral, is the anterior, is the
Ma'am,
posterior? It all known
lateral
is anterior
compartment.
compartment. Lateral compartment is peroneal muscular atrophy.
Yes,
Posterior
ma'am.
compartment is myoshi myopathy, no? So you describe the compartment, it will click on your brain. What am I dealing with? No? So that way you tell. So you have
Yes,
a
ma'am.
pes cavus and you have got a muscle wasting, which is more involving the lateral compartment, relatively sparing the thigh muscles.
Thigh muscles.
Our thigh muscles are better, not sparing.
Better.
Thigh muscles are
Yes,
better.
better preserved. Yes, ma'am. Yes, ma'am.
Next.
Ma'am, there is no signs of angular cheilitis, glossitis, or knuckle hyperpigmentation. No Targetson or Walker-Muddots and Steinberg. The signs of Marfan's and Ehlers-Danlos. No signs of hyperpigmentation, oral ulcers, salivary gland swelling, dry eyes, no hair loss of extremities, or button lines on the gum of the teeth. No thickened nerves present. No fasciculations present.
So among
Coming to higher
what
mental
is the
functions.
most important thing when you are doing the general examination, no? Okay, go on, go. It is general examination you are telling, no? What you told about all these cheilitis and all those things? You mentioned about cheilitis and all
Vitamin,
those.
vitamin B12 deficiency.
Okay. Okay, ma'am.
Yes, ma'am.
Oh. So you are describing the general examination.
Yes, ma'am. General
Appearance
examination.
of the feet and others. Agreed. Yeah. My teacher used to tell that always end the general examination by skin, hair, nail, tongue, teeth, tonsil. And throughout
Yes,
my
ma'am.
life, he helped so much. Skin, hair,
Yes,
nail, you should, and tongue, teeth, and tonsil. So
yes, ma'am.
many neurological diseases have clues in these areas. So just quickly
Yes,
look
ma'am.
at skin, hair, nail, tongue, teeth, tonsil. Okay.
Yes, ma'am. Now coming to higher mental functions, language, speech, volume, and phrase length, comprehension, naming of objects, repetition, reading, writing, calculation are normal. Mini mental score exam, MMSC score is 30 out of 30, and lobar functions are normal. And cranial nerve examination, ma'am, I am unable to write it in a form of a table. Can I?
Okay, you can tell me, is there anything, which cranial nerve is positive?
Ma'am,
Any cranial anything?
No positive signs in the cranial nerve examination.
So in a small child having bilateral pes cavus, even though he told unilateral disease, after examination he found it as bilateral lateral compartment wasting and bilateral pes cavus. No, what all the cranial nerves you will focus? You should specifically look for clues. You look at the optic nerve.
Optic, yes, ma'am. Yes,
And then
ma'am.
you look at the auditory nerve. You
Yes,
will
ma'am.
look at the fifth nerve. No?
Yes, ma'am.
Digerin sota type of neuropathy. Fifth nerve gets involved.
Yes, ma'am.
So you will have to carefully look at the optic nerve, eighth nerve, fifth nerve. They are affected in patients who have got pes cavus.
Yes, ma'am.
And that point to some group of diagnosis. No? So that you have to focus. And if they are not involved, okay, it's not involved. Okay, then.
Yes. Ma'am, hand grip during a handshake is normal. Tone is normal in all the four limbs. High step gait is observed. He is able to walk on toes but not able to walk on the heels. Child is able to get up from sitting position without using hands.
Clearly a foot drop. No?
Yes, ma'am.
He's not
Ma'am,
okay,
yes,
go
ma'am.
on.
He is able to do 4 push-ups. Ma'am, bulk I didn't measure the circumference.
Actually, you should measure or not?
Yes,
because
I should
you
measure.
told so much of asymmetry, no?
Yes, ma'am, I should measure. Yes, ma'am.
You should measure because you told so much asymmetry in the history.
Yes,
and now
ma'am.
it is your duty to prove it is not at all asymmetry. It is the subjective observation of the patient, no?
Yes, ma'am. Intrinsic muscle movements, no fasciculations, myocymia or cramps noted. Tenderness, no tenderness of the muscle groups observed on palpation. Consistency, all the muscle groups are of normal consistency. Percussion of thenar muscles, tongue muscles, wrist extensors showed normal contraction. No myotonia and myoedema observed. No contractures observed.
Tender Achilles, he's having pes cavus, no, ma?
Yes, ma'am. No contraction of the tender. Yes, ma'am.
You have a patient's leg, because when the patient is walking on toes and he has pes cavus, usually tender Achilles will be short only. So if we can show his foot, we can see. It will be short, generally.
Yes, ma'am.
What's the difference between a contracture and a pseudo-contracture, ma'am?
Yes, ma'am. Ma'am,
Sure
contracture.
will have tender Achilles contracture, I'm sure. No?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
What is pseudo-contracture? What is contracture, ma'am?
Ma'am, contracture,
because you told all those things. There is no cramp, no contracture, like that only you told, no?
Yes, ma'am. Contracture, there is thickening of the tendon. In the pseudo contracture, it is just the length of the tendon is reduced, but there is no.
You see, ma. Another point I'll tell. You see,
yes, ma'am.
Medicine is so vast, we cannot learn even 1 in million of that in one Janma. No? So if you do not know something, the next important thing we should learn is to learn to tell I don't know.
Yes, ma'am.
See, ma, pseudo-contracture means non-contractile component of the muscle going into shortening. What was non-con is the tendon. So tendon contracture is a pseudo-contracture. Actually, conventionally, we say it as contracture. But
Yes, ma'am.
tendon is not a contractile component of the muscle. When
Yes,
there is an asymmetry in the power between the dorsiflexor and the plantar flexor over a long period of time, in the plane of the powerful muscle, the body part will be pulled. And that because of the more powerful and it remains pulled that way, that goes into contracture. So that
yes,
is one explanation for tendon contracture. Another explanation is a child. He may have a muscle or a nerve disease, but his bones
ma'am.
are normal. And all these muscles are attached to the bones. When the bones grow and the muscles and nerves do not allow them to grow as fast as their bones, these tendons become stretched from their attachment to the bones and degenerate. So these are the postulated mechanisms for contracture. One is disproportionate growth of the bones and the tendons getting stretched. Second, asymmetry between the two group of muscles. So the muscle which is stronger becomes short and pulls the joint in its plane. So that is a non-contractile element. Whereas real contracture is a painful shortening of muscle that we call cramps and contractures. See?
Yes, ma'am.
They are energy deprived muscles. It can, physiological cramps are very common, especially old people like me. See, we get microvascular ischemia when we grow older and you get cramps. So that is energy deprived state of the muscle due to accustomed action in a normal muscle or unaccustomed action in an abnormal muscle. Supposing we are not used to 400 meters dash, no? We run.
Yes,
Any
ma'am.
young person will develop a cramp.
Yes,
Whereas
ma'am.
a person who is old, diabetic, microvascular ischemia is there, when they are simply resting also, they will get a cramp. That is a true one. And contracture is pathological, myophosphorylase deficiency, mitochondrial disease. It is always accustomed exertion, they go into shortening. So true contractures are cramps and contractures. Whereas cramp is sometimes physiological, as I told, unaccustomed work. When in accustomed work it is occurring, it is pathological. But when it can also occur in unaccustomed action. And when you do an electrophysiology needle, it will be silent. That you need not learn. EMG needle will show silent. Whereas myophosphorylase deficiency, mitochondrial diseases, where the shortening is electrically silent. That is how these two are differentiated, cramps and contracture. And those silent ones are always pathological.
Yes, ma'am.
So you get a shortening, which is painful. You do the EMG needle, it is not showing any discharge. It indicates mitochondrial disease or myophosphorylase deficiency. Whereas it is active, then it can be a physiological contracture due to unaccustomed exertion or pathological contracture in a microvascular ischemia. Whereas pseudocontracture is non-contractile component getting shortened due to disproportionate growth of the bone, or it is due to unopposed agonist antagonist. Agonist is weak and antagonist is strong. It will pull in the plane of the antagonist. So this boy, I am expecting a contracture. If he can show his leg, I can demonstrate. Okay. So that is the difference. Then what else more? Go on. You said cranial nerves are normal.
Yes, ma'am. Ma'am, coming to the power examination of the muscles, ma'am, the positive find the movement of the shoulder joint, the flexion extension, all the abduction, adduction, internal rotation, external rotation are 5/5 in both the left and right side, and movement at the elbow joint is flexion and extension are 5/5 and bilaterally, and movement at the wrist joint is flexion, extension, abduction, adduction are 5/5 bilaterally. Movement of the hip joint, flexion, extension, abduction, adduction, external rotation, internal rotation are 5/5 bilaterally. Ma'am, movement of the knee joint flexion is 5/5 and bilaterally, and extension is 5/5 bilaterally. And at the ankle joint dorsiflexors, the power is 3 plus of 5 bilaterally, ma'am. And the toe flexion and extension, it is 3/5 bilaterally. Toe grip is absent.
Plantar flexion? Dorsiflexion, you told, you didn't tell about the plantar flexion.
No, plantar flexion is 5 by 5. Plantar flexion is 5 by 5.
So there will be contracture.
Yes, ma'am. Yes, ma'am.
Then, oh, go on, reflex. Power, tone. Next is tone.
Ma'am, tone is normal in all the 4 limbs.
Yes. Then,
Ma'am, deep tendon reflexes, the knee jerk is they only positive finding is brisk knee reflexes are present bilaterally, madam.
What about angle jerk, ma'am?
Ma'am, ankle jerk is a normal 2+.
So angle jerk is normal. Knee jerk
Yes,
is.
ma'am. Knee jerk is brisk.
So what do you think could be the reason for this asymmetry?
Ma'am,
both reflexes may be brisk only. When there is a tendon contracture, the briskness will not be visible due to the contracture. So I am sure you should, if you go back and see your patient, I am sure there will be a shortening.
Yes, ma'am.
About plantar? Plantar reflex?
Ma'am, equivalent bilaterally, ma'am. Equivalent bilateral.
Flexor or extensor?
Ma'am, it is extensor, ma'am. It is extensor now.
Abdominal reflex?
Ma'am, abdominal reflex are absent, ma'am. Absent.
Okay. Okay, ma'am. That's all?
Ma'am, sensory examination, there is no positive sensory findings.
What is it that you should carefully look for? You said inverted champagne bottle and all those things, no? Then what is it that you should carefully look for? Timed vibration. You see, inverted champagne bottle is usually associated with proprioceptive impairment, which may not be symptomatic, no? So you should look for timed vibration. In a young child like this, over the angle, they should appreciate for 15 seconds.
15 seconds, yes, ma'am.
With the anterior spine, at least 20 seconds. So you have to use a proper tuning fork and looked at the timed vibration. That's very, very important. Then, ma, you looked for, did you look for?
Ma'am, I looked for vibration sensors, ma'am. It's intact.
How many seconds? Did you time it or just?
Ma'am, it is more than 15 seconds, ma'am. It is more than 15 seconds.
Okay. Okay.
Yes.
Other systems?
Ma'am, Romberg sign is negative. Cerebellar test, finger to nose test, bilateral normal. Heel to shin test, normal bilaterally. Dysdiadochokinesia, it's normal bilaterally. Rebound phenomenon absent bilaterally.
What about the nerves? Did you palpate all the nerves?
Ma'am, I palpated for the great auricular nerve.
All the nerves you should palpate, no, ma'am. So you told that you have got an inverted champagne bottle. What do you find in those patients? You will find thick nerves. Unlike Hansen's disease, where the nerves are beaded, thick and beaded. Whereas uniform thickening of these nerves will be found in patients with charcot-marie-tooth disease, hereditary motor neuropathies or motor sensory neuropathies. Then you will have soft succulent nerves. The nerves will be big but compressible. In what condition? So beaded and thick in Hansen's disease, uniform thickness without beading in hereditary neuropathies, and you will find soft, succulent, juicy, but big nerves. Digerine sota.
Yes, ma'am.
Digerine sota. So you should palpate all the nerves in a patient. So now after examination, you feel it is a symmetrical disease.
Yes, ma'am.
There is combined involvement of lower motor and upper motor. So it's a motor system disease involving both the lower motor neuron and the upper motor neuron. The lower motor is the small muscle wasting, pes cavus, and the wasted legs. Whereas upper motor neuron is the absent abdominal reflex, exaggerated knee jerk, well-elicited angle jerk, and upgoing plantar. So it's a motor system disease which involves both the upper motor and lower motor, and it is symmetrical. So what are the conditions where upper motor, lower motor system gets involved? What are the conditions they get involved?
Ma'am, vitamin vitamin B12 deficiencies. Some,
Vitamin B12 deficiency, what do you get, ma'am?
ma'am,
You can get a neuropathy,
regeneration.
you can get a myelopathy, but it
Myelopathy, yes, ma'am. Myelopathy.
sensory
Yes, ma'am.
motor.
Yes, ma'am.
Subacute combined degeneration.
Combined degeneration. Yes, ma'am.
So
Yes,
you'll have posterior column and pyramidal tract, and you will have sensory motor peripheral neuropathy. So it is
Yes,
not
ma'am.
B. So what other conditions, ma'am? So upper motor, pure motor disease, which is upper motor and lower motor, first diagnosed androcortical disease only.
Yes, ma'am.
Motor neuron disease, we say purely LMN, purely UMN, LMN plus UMN. So I am
Yes, ma'am.
dealing with the juvenile form of ALS.
Yes, ma'am.
So you clearly told that there is no fibrillation, there is no vesiculations, there is no involvement of bulbar muscles, pseudobulbar muscles, and upper limb is spared, and it is a symmetrical LMN syndrome. LMN and UMN syndrome involving predominantly the leg. So usually the ALS starts in the upper limb with a lot of signs. You called as a
Yes,
cut hand syndrome and all. The hand will look like cut into two due to the asymmetry between the thenar and the palmar muscles. And you get the bulbar muscle signs, symptoms may not be there. And lower limb involvement
yes,
will be usually UMN alone. So
yes,
ALS patient starts with wasting of the small muscles of the hand, resulting in a cut hand appearance. Then they develop neck, bulbar, and UMN signs in the lower limb. Whereas in your patient, UMN upper limb is totally spared. And it is very, very symmetrical. With juvenile ALS is there, but it is less common. So UMN and LMN combination, first you'll think motor neuron disease. Is it a juvenile form of ALS? But some points are against. So you keep it like that. So next, what are all the situations where you get a combination of, you told about inverted champagne bottle condition, and you can tell about acute conditions. Acute condition, you told subacute combined degeneration, but significant sensory will be there. It is not there. So acute UMN and LMN, you get in paraneoplastic myeloneuropathies, demyelinating myeloneuropathies, HIV-associated myeloneuropathies, copper deficiency myeloneuropathies, and you get myeloneuropathy due to sarcoid, and you can get it due to B12, as you told. But each one is unique.
Yes, ma'am.
And none of those things you are suspecting in this case. B12 you are not suspecting because even though B12 deficiency is very common in that part of India, I have felt that there is some kind of absorption defect. It's very much common, even though most of us are vegetarian only. It is very much common in those parts of that Karnataka, that area. I feel that there is a transporter or a absorption defect. So you think of that correctly. What is the name of the condition which affects B12 transporter, transcobalamin 1 and 2? There is one condition. Runs in family. So it will closely resemble inherited neuropathy. That's called Emerson-Gaisbach syndrome. That's the transcobalamin 1 and 2 deficiency. It will have UMN, LMN, but sensory will be there. And you will think, because many members in the family are affected, you will think that it is a degenerative disease, but it is highly treatable. B12, even if it is absorbed, it is not transporter. Because of the transcobalamin 1 and 2 deficiency, you have to parenterally supplement B12, they will become normal. So that is all acute condition. HIV associated, you are not having other features of HIV. Copper deficiency usually happens when the patient is taking long duration zinc, COVID season, everybody swallowed zinc.
Yes,
or you take zinc in the treatment of conditions like Wilson's disease. Then they get the zinc deficiency myelopathy. Sarcoid will have other features like lung signs, uveitis, plus you can have a myelopathy. So other features of these conditions, acute or not there, you should always think of acute conditions because they are treatable.
Yes, ma'am.
When you proactively, not by exclusion, you think of inherited conditions when? One, signs are more, symptoms are less.
Yes, ma'am.
You told that he is having only one leg. No?
Yes, ma'am.
That means his symptom is very less.
Yes, ma'am.
But signs are more. What would have happened? This boy might have developed a asymmetrical weakness due to some pressure on one leg, that you would have appreciated, but you would
Yes,
have
ma'am.
never been normal. Their
Yes, ma'am.
symptoms are very less because they don't know what is normal.
Yes, ma'am.
You would have never been normal. You would have never had a normal motor milestone.
Normal.
So,
Yes, ma'am.
inherited condition is suspected when symptoms are less. They complain
Yes,
very less. And you examine that, there are so many signs
Yes, ma'am.
that your patient is having. His symptom is one leg, which was probably
Sign.
secondary to some secondary compression or pain or on that leg, which brought out his symptom.
Yes, ma'am.
But signs are symmetrical. That's a very important feature. Symptoms are less, signs are more.
Yes, ma'am.
Second, family history. If there is a family history, it is helpful.
Yes, ma'am.
Third point is positive symptoms do not occur.
Yes, ma'am. Positive symptoms.
There will be fasciculation, fibrillation, cramps,
Yes.
contractions. That will not be there. With reference to sensory, if it is a hereditary sensory neuropathy, paresthesia, dysesthesia,
Parasitic.
that
Yes,
will
ma'am.
not be there.
Yes, ma'am.
So in an inherited neuropathies, there will be no positive sensory or motor. So 3 points. One is symptoms are less, signs are more.
Yes, ma'am.
Exactly what you have shown. No?
Yes.
When we discussed with the symptom, it was different. When you discuss with the signs, it is different. Second, if
Yes,
there is a family history, then absence of positive features, either motor or sensory. These are the points. So all you have got more signs, less symptoms. You have no positive, which clearly told. And is it distal
ma'am,
is
if it is
involved in proximal? So it could be at the level of a nerve. You should have palpated all the nerves. Then we might have found
yes, ma'am.
some thick nerves. So because distal is
Yes,
more involved. Usually muscle diseases, other than the distal myopathies, they involve the proximal. There are distal myopathies, as is told, Miyoshin, Onega, all those muscle diseases. So you can seriously, but your reflexes are exaggerated. The knee joint.
Yes, ma'am.
That doesn't happen in the muscle disease. So in the muscle diseases,
Yes.
angle jerk will be preserved. Other reflexes are usually lost. You can have hypertrophy, hypertrophy. You can have selectivity, segmental atrophy. That is the feature in muscle disease. EDB, extensor digitorum brevis, will be very big. In muscle disease, extensor digitorum brevis will be hypertrophic. There will be segmental atrophy, segmental hypertrophy. Usual reflexes are absent and angle jerk is retained. In your case, all the small muscles are wasted. EDB is not standing out. But reflexes are retained because of the myelopathic involvement. And the distal is worst affected with the deformity and chapel slipping off without grip. So the distal most intrashi is also affected, so his chapel is gripping off. So distal involvement, symmetrical involvement, wasting, and asymmetrical contractures, that is element. It is respecting a nerve because there is no selectivity, there is no EDB hypertrophy, and there is no loss of reflexes, and therefore it is probably a nerve. Distal most is involved. EDB is atrophic. I told the nerve pattern is distal most. I told you first, the axoplasmic flow. The distal most is worst affected. EDB is also atrophic. And there is there is no pseudohypertrophy, no segmental atrophy. So all these things are favoring a probably a nerve. Yes, you have got an upper motor neuron involvement. And positive features are not there. So that will favor a probably an inherited purely motor syndrome. So you can discuss all those things. You have got motor sensory neuropathies, charcot-marie-tooth, several types. They are all motor sensory, where the proprioception will be involved. And you have got pure hereditary sensory, where only sensory. And you have got sensory autonomic. And you have got pure motor syndrome. So the pure motor can be very many types, depending on pure motor with optic atrophy, pure motor with spastic paraplegia, pure motor with deafness. And you have got pure motor proximal, that is SMA. And you have got pure motor with contractures.
Yes, ma'am.
And you have more than 30 genes, no?
Yes.
Described in this condition. So this can be an inherited condition because his symptom is less, signs are more,
Yes.
symmetrical, respect
Symmetrical.
nerve pattern, no? And there are no positive features.
Yes, ma'am.
So it could be an inherited motor dominant neuropathies possibility.
Yes,
and it will fit into the motor neuropathy with spastic paraplegia. I've got
Yes, ma'am.
motor neuropathies with optic atrophy, motor neuropathy with deafness, motor neuropathy with this one, what is this, myelopathy, and you have got proximal motor neuropathies, that's the FMAS, and motor neuropathies with contractures.
Yes.
So there are different genes. So in this case, what you should
Yes, ma'am.
learn, how to analyze the history, how to motor system involves corticospinal tract, upper motor, lower motor, cerebellum, basal ganglia. So under this, how to differentiate various upper motor, lower motor, and how to understand all the patterns, the nerve pattern, anti-Honsel pattern, and muscle pattern, I told you, neuromuscular junction pattern, and plexus. Some group we discussed, you can study all other nerves, the upper limb, femoral nerve, tender nerve, no? So that is what you learn. And at the end, you can tell a probable diagnosis.
Yes, ma'am.
And his milestones would have been delayed. You told it is normal. Mendel
Yes, ma'am.
milestones would have been normal. So
Yes, ma'am.
very unlikely you have to go back and ask. No? After examination, you become wiser now. So you can say it is fitting India, purely motor, LMN plus MN syndrome, probably inherited because there is no positive features and symptoms are less and signs are more. And the child is very young and he may have palpable nerves. You should look
Yes,
at them.
Yes, ma'am.
So that will be sufficient. So how are you going to treat him? You have to prevent the, already has gone into pestivus. So by proper exercises and external appliances, you have to prevent his contractures.
Yes, ma'am.
Otherwise, when he grows old and he will not be able to walk at all. So to prevent contractures, you have to do external appliances. No? Then you should advise him not to put on weight.
Yes, ma'am.
Then he will buckle and fall. There is no specific treatment in these conditions. There are treatable motor neuropathies, that is porphyria, amyloid, adrenal neuropathies, where you can do bone marrow transplantation, or you can do liver transplantation in amyloid. So those kind of motor neuropathies with systemic involvement. Porphyria, you can avoid the precipitating things and you can take high glucose. So those kind of systemic diseases with motor nerve involvement have some treatment options. Whereas other ones, we tell that you can use high dose vitamin C. That's recommended.
Yes, ma'am.
And otherwise, some people use progesterones, but because they are having hormonal complications, it is not used. And brain-derived neurotrophic factors, they are not available for usual access. No? So proper external appliances and regular physiotherapy to prevent the child going into rapid contractures. Tell him not to put on weight. Weight will be fat, not muscle or nerve. And then give him vitamin C in high dose, taking care that he does not develop renal stones. That's a common. So good, ma. Any doubts you can ask? So I have just told you how to approach.
Yes, ma'am.
Any doubt you ask?
Ma'am, I have been asked whether if during genetic counseling, if should he be regarding the advice for the marriage and for the raising next progeny, should he go for marriage and give?
What about his parents? Are they positive for any of these? Are they
No.
Sanger sequencing you did?
Ma'am, his splice variant mutation is observed in this, ma'am.
The child in his parents.
Yes, ma'am. I don't know about the genetic testing of
So he's only 10-year-old. His parents may be in a childbearing age only. No?
Yes, ma'am.
So you have to advise his parents.
Yes, ma'am.
Is it a mutation or is it a inherited one? So mutation is a stable, heritable change in the gene. It can happen in healthy parents. So if the parents are in the childbearing age group, you have to
Yes, ma'am.
tell the parents to do their genetic testing. If they are
Yes, ma'am.
negative, they are safe.
Yes, ma'am.
So if they are positive, then you have to advise them for prenatal screening of any subsequent babies they are going to get. For this
Yes, ma'am.
child, you have to clearly tell that there is no gene-based treatment options available at this point of time. So this
Yes,
child
ma'am.
will be slowly deteriorating. So no
Yes, ma'am.
question of him getting married. So you
Yes,
will not
ma'am.
advise all those things. So you should tell them that he has to have a physical independence and economic independence.
Yes, ma'am.
For physical independence, at one point of time, he will need external support.
Yes, ma'am.
And economic independence, educating.
Yes, ma'am.
That's all. That's all. No?
Thank you.
He will not be getting married. So I
Yes,
have to tell him. No?
Yes, ma'am.
Okay. First,
Ma'am,
you have
any
to
book?
check the book.
Ma'am, any books? Yes, ma'am.
See, I got a Dick and Lambert approach to peripheral nerve. And I got a short continuum series on peripheral nerve. But what
Yes, ma'am.
at your level, ma, you
Ma'am.
don't think of the genes and all. You see, we should not make life miserable for our patients unless my teachers have told me, you do a test, if it will help science or it will help patient.
Yes, ma'am.
We are doing a research project. When I was in NIMHANS, many things I used to do because it is funded and the patient doesn't lose and it is for research purpose. So it
Yes,
should help science or it should help patient.
Yes, ma'am.
We don't have gene-based therapy now. So it's not going to help the patient. Unless in his parents you can do. If they
Yes,
are
ma'am.
still wanting to have babies. This boy you have to tell him. No?
Yes,
And then so gene-based therapy is not there. So I will not do genetic. What you should learn is how to fix a case. You see, patients with hereditary neuropathies can develop Hansen's disease. They are
Yes,
called
ma'am.
collision syndromes. So if you do not know how to place each syndrome, you will miss those cases. They can
Yes,
have
ma'am.
CADVs. Patients with hereditary neuropathies can have CADV. That part is correctable. So
Yes, ma'am.
carefully analyze for the nervous system, careful analysis of the symptom history and placing and genetics only if it will help science or help patient.
Yes, ma'am.
It will help patients in this patient if his parents wants to have more children.
Yes, ma'am.
Then otherwise ideal will be to adopt healthy children. So many children have no parents in this country. It is such a great thing. Lord Krishna is an adopted child, you know. No? She was adopted by Devagi. No? So you
Yes,
have, sorry, Yasoda. So you have to tell that, then only they will understand. It is such a noble act. Everybody brings up their own children. Bringing up another person's child is very wide. So if they want to have a normal child, best to get another child. Or if they want, you can do the genetics for them. At this point, routine nerve evaluation in a routine practice setup should be helping patient oriented. So thorough clinical examination, that is what is needed. Anything else, Ma? Any other question? No? Should we stop? What happened, Ma? Should we stop or what? What happened to Dr. Gowtham Varma? Should we stop, Ma? Any other doubt also you can ask. He left. Okay. Why did he leave so suddenly? What happened? Okay, nice one. Thank you.